All right. Well, it's 1:01 New York time here on my clock, so I think we'll get started. I'm sure people will continue to join. But welcome, everybody. Thank you for being here with us today. Welcome to Ask the Experts. This is the first of our two Ask the Experts session that we're having today, always a popular session at our conference, where we bring together a few wonderful speakers to answer all of your questions. So we're very lucky to have with us today Dr. Anil Sood from MD Anderson Cancer Center, who will sort of be our master of ceremonies today. Dr. Karen McLean from Roswell Park Cancer Center in Buffalo, New York. And also Dr. Premal Thaker from the Siteman Cancer Center in St. Louis. She has been caught up in her doctor duties, and I don't think she is here with us yet, but that's fine. She will be joining our panel of experts just as soon as she can. So just a little bit about how we're going to organize our session or the sessions today. A lot of you submitted questions in advance, which was great. We're going to start with those, but do submit your questions in the chat as well. We will be monitoring them and pulling them together and probably answer most of those in the second half of our session today. We will take a break in between, about a 10-minute break, so you can run to the bathroom or reheat your coffee, whatever you need to do. So yes, questions in the chat. If you can't stay for the second half of the session, and are worried that you won't hear the answer to your question, don't worry. We are recording this session. It will be available to you later, so you can go back and listen and hopefully hear the answer to your question. So I think that's it. Oh, the last thing I wanted to say is in terms of your questions, our doctors can't provide any medical advice today or advise on the specifics of your situation. I just wanted to put that out there ahead of time. Okay, so with that, I will turn it over to Dr. Sood and Dr. McLean to take us away, and thank you.
Thanks so much, Sarah, and really appreciate all of you joining us. And we have quite a few questions. And what I thought I would do is many of these kind of cluster around specific topics. So we'll go ahead and get started on specific areas, and then we'll kind of alternate between the areas just to make sure that we cover as many questions as we possibly can. So let me start with a question for Dr. McLean, if you could help us with this. Do PARP inhibitors assist in keeping stromal sarcoma at bay or in check?
So this is a great question, and really, I think gets to one of the themes that we'll have today, which is the complexity of ovarian cancer as not just one disease, but many different diseases. And even within the broader subtypes, such as stromal tumors versus epithelial tumors, there are subtypes there also. And so I would say that at this stage, we have mostly studied PARP inhibitors in those epithelial tumors, high-grade serous ovarian cancers, but other epithelial tumors also. And they really have not been studied in stromal tumors in the same way to have the data to say that they're beneficial in that tumor type.
Thank you. And so another question that was raised is, what's the typical length of time of treatment on a PARP inhibitor? Is it 1 year, 2 years, 3 years, and so on? So I'll go ahead and start on this, and Karen, feel free to add in. You know, with a lot of the indications that were present for upfront use, typically the PARP inhibitors, depending on which one was we're talking about. So, for example, olaparib was approved for a period of 2 years for upfront maintenance, and niraparib was approved for a 3-year time period. Now, in a relapse setting, and it's a lot of that has been revised, and I know that'll come up during the discussions today as well. There was no absolute timeline, meaning that they could be continued for an extended period of time. But boy, a lot's changed over the last about 3 years or so. And there have been concerns raised about the risk of a secondary malignancy or a secondary cancer, especially something called MDS, and also a form of leukemia called AML. And this is, by the way, a spectrum between MDS and leukemia. And it seems that the risk of these secondary cancers is particularly high in patients who were getting a PARP inhibitor in a relapse setting where they had already had quite a bit of exposure to platinum-based drugs. So many of us now become, for those patients who've been on it for quite some time, we're starting to counsel patients, especially about the risk of these secondary cancers, and then perhaps to think about stopping the PARP inhibitor after a period of time, be it 2 or 3 years. And even in the upfront setting, some of the data would suggest that most of the benefit from PARP inhibitors likely occurs earlier on, meaning in the first 15 to 18 months or so. So continuing it indefinitely, I think it's a really careful discussion that patients should have with their physician. But we certainly worry about the risk of secondary malignancies. Karen, I don't know if you wanted to add anything to that.
I very much agree with the things you said, particularly this topic of upfront maintenance therapy versus the recurrent setting, both for duration of therapy and risks and benefits. And I think that one of the things we can do as providers is be really clear in the beginning when we're starting that medication to talk about these pros and cons and how long we recommend someone stay on the medication so it doesn't catch them off guard when we reach maybe that 15, 18 month or 2-year mark.
Thank you. So Karen, now I'm going to shift categories and we'll come back to PARP inhibitors because there were lots of questions around PARP inhibitors. But this relates to genetic mutations and biomarkers. So Dr. McLean, can you explain the P53 mutation and its relationship, if there is any, to recurrence and how it affects those in a patient's family?
Sure. So P53 is a protein that we all have in all of our cells that is almost always mutated or abnormal in women with high-grade serous ovarian cancer. In general, this mutation or alteration is coming up during the cancer formation. It's not a mutation that gets inherited from your parents, except for in very rare situations. And so it is, we say, ubiquitous, or it's seen in really all of the tumors. And because of that, there have been research strategies to try and develop treatments that might build off this alteration in the tumors. Still an area of study in hopes that we can find an approach that takes advantage of this genetic change.
Thank you very much. One thing I'll add is that there is a genetic syndrome called Li-Fraumeni syndrome, where patients can carry it's not a particularly common syndrome that we see, but there are patients who can carry a P53 mutation in what we call germline, meaning that it's present in every cell of their body, and they can pass it down to other family members. Now, what's unique about this particular syndrome is that patients can be at risk not just for ovarian cancer, but also many other types of tumors, including brain tumors, breast cancers, and so on. So I think if that has been diagnosed in a patient, then a very close conversation with the genetic counselors as well as the oncologist is critical, so that appropriate screening and possibly some prevention strategies could also occur. Next question is, should the biomarker testing of the tumor be done at the time of the debulking surgery or wait until the cancer comes back as documented on a CAT scan and CA-125 level? And there was a little bit more to this question. This is such an important question. And I'll go ahead and start on this, and then I'll ask Dr. McLean to also comment. Biomarker testing can look very different depending on the subtypes of cancer. And like Dr. McLean mentioned, ovarian cancer and really many cancers, it's not just one disease at all. There are many, many different subtypes. But let's use, for example, high-grade serous type of ovarian cancer as an example. Typically, here what we would tend to do is, in an upfront setting, offer the germline BRCA testing to our patients. And then those who don't have the germline mutation, then they would automatically have what's called reflex testing of the tumor, including something called HRD or homologous recombination defects. And the reason that's so important is because this goes back to the prior question in terms of use of PARP inhibitors for maintenance in the upfront setting. Now, there's additional testing that can be done on the cancer samples, including testing for a lot of different mutations within the tumor, and also now increasingly doing testing for things such as the folate receptor or a protein called HER2 that can also be important for antibody drug conjugates and some of the recent approvals. And I know there are going to be questions that come up around those topics. But a lot of times, we'll prefer to wait to do that particular type of testing if someone has relapse, to do it at that time. And the reason is as follows, in my thinking. One is that, see, if somebody doesn't have relapse for a 2-year period, well, the number of genes that are sequenced, continues to expand literally year over year. And we would have a much broader panel at that point down the road. The second thing is that, not uncommonly, we would recommend doing a biopsy to, number one, prove that there's recurrence. And at times, even for things such as folate receptor or HER2, we'll prefer to do the testing on the more recent tumor because we know from experience that some of these biomarkers can actually change in terms of their extent of expression, depending on whether you look up front or in a relapse setting. So for those reasons, a lot of the testing, especially focused on the tumor, we'll frequently do in a setting if somebody does have relapse. Karen, would you like to add?
Yeah, I'd like to add that really when I think about this question at the core or any testing we're doing, it's the question of how are those results going to change our management? And so in the upfront setting, when folks are first diagnosed, really what we're trying to determine is which patients are going to benefit the most from a PARP inhibitor. And those are patients with BRCA alterations, either that they inherited or that arose in the tumor, or these changes called homologous recombination or HRD that Dr. Sood referred to. And so that's really the upfront question. Should a patient get a PARP inhibitor? If that testing is negative, then I also usually do the practice pattern where we wait until recurrence so that we get the most accurate biopsy of what's the cancer looking like and behaving like then. And maybe there are new treatments and new tests that we want to do at that time to help us to guide those next decisions.
I see that Dr. Thaker's also joined us, so I'm going to go ahead and bring her into this conversation. And Sarah, did you want to introduce her in any way, or do you want me to just go ahead and keep going?
Welcome, Dr. Thaker. Thank you for fitting us in.
Sorry, I was finishing clinic. I apologize.
Of course. Well, first things first, I think we would all agree with that. Thank you so much for joining us.
Thank
So,
you.
Premal, what we're doing is Sarah passed on several of the questions that were already asked. And so we'll go for about 50 minutes, then take a 10-minute break, and then we'll do a second 50-minute session as well.
Okay, great.
So, Premal, right now we're just going through the different categories of questions. So here's a question for you. If it's a highly individual question, like Sarah mentioned earlier, then it's hard to answer, for a patient specific. But in this question, what was brought up is, should the daughter of a woman who died of ovarian cancer get a hysterectomy as prevention? What is best prevention?
Yeah, so that's a great question, because as we know, there's many patients who have ovarian cancer do have a genetic predisposition. And if the testing hadn't been occurred or something like that. I think it's an individualized discussion, and actually getting genetic testing would make a lot of sense, because there's lots of nuances to what might happen after you have a hysterectomy. And so I think it's one of those that you have a discussion, and I don't think it's a knee jerk. My mother had ovarian cancer, I should have it, because it depends on the age. It depends on sort of what your also future, if you want to have childbearing, because there's lots of women, as soon as they hear this, are like, well, I'm now 30 and I want to just do that. And people, as we know, are delaying childbearing. So I think it's not as easy of a decision. And sometimes you have to have that discussion, but genetic counseling is available. And I'd really strongly encourage that patient to get genetic counseling to help guide that discussion.
Thank you. Dr. McLean, here's a question that I'll pose to you. What specific biomarkers and genes that look to provide guidance on the appropriate treatment could benefit a patient with ovarian cancer? Does testing that detect MSI inform MMR biomarkers, and when should those be done?
This is a good follow-up to our last discussion about the biomarkers and BRCA status and HRD. With respect to MMR status, which is short for mismatch repair or microsatellite instability, these are genetic changes that we see in a subset of ovarian cancers, but much less common than in other gynecologic cancers, such as endometrial cancer. And so there's a subtype of ovarian cancer that looks like endometrial cancer. Sometimes those patients will have mismatch repair deficiency. And there is now treatment and data to show that immune checkpoint blockade can be beneficial in patients that have these alterations. I would again circle back to reiterate that these approaches are generally used in the recurrent setting. And so to the question of when should such testing be done, it is information that we can get in broad genetic testing that's done as part of an analysis of a recurrence.
Thank you. I'll address this question. The next question is, are there any advances on related to mucinous ovarian cancer, especially around genetics and biomarkers? Boy, this has been a really a tough type of cancer to treat. We know from a lot of studies that this particular cancer, if it comes back, tends not to respond as well to chemotherapy. Some of the things that we've learned around mucinous ovarian cancer are, number one, it's really important to try to prove as best as possible that it's not coming from somewhere in the gastrointestinal tract. In our experience, when we look at these cancers, they can actually come from the appendix, they can come from the stomach, the pancreas, and other areas of the upper gastrointestinal tract. And as our pathologists carefully look to and really try to prove, hey, where is this coming from? If it's coming from a gastrointestinal source, then typically we'll work in collaboration with the GI medical oncologist for treatment. There are many other things that we've learned, such as that the way that these cancers invade, there are differences. There's something called expansile versus infiltrative pattern of invasion, and that does affect in terms of how aggressive these cancers can be. Here we've also started to use a regimen for chemotherapy that would typically be used for patients with colon cancer. And there is some data that would suggest at least that this kind of a regimen may actually be better than using the traditional chemotherapy regimens that we use for patients with other types of ovarian cancer. And then finally, there are specific markers such as HER2, such as presence of KRAS mutations, P53 mutations that we see more commonly in patients with mucinous cancer. Now, to what extent these actually can be used for effective therapies, I think that still kind of needs to be proven, especially with the new drugs such as Enhertu. We're certainly testing that. And we also have a clinical trial now, if a patient with mucinous ovarian cancer has relapsed, then to do a fairly aggressive surgery, including, and then also including HIPEC or heated chemotherapy within the belly as well. So there's certainly a number of advances, but this is clearly an area that needs a lot of work to improve upon the responses and so on. Let me ask Dr. Thaker this next question. Are there specific genetics and biomarker tests for leiomyosarcoma? If so, what are they? And if not, why not?
Great question. So leiomyosarcoma is a very hard disease to diagnose, as we've all been trying to figure out how to diagnose it even on imaging or try to preemptively know. Most of us find out after the fact on pathology. I'd say there really are not great genetic markers for leiomyosarcoma. A lot of us will do profiling, like we've probably been mentioning, a lot of molecular profiling of the individualized tumor, because a lot of these tumors will have their own abnormalities, and we do know that there are some. Dr. Sood mentioned, N-HER2 or the HER pathway being abnormal. And so there are some leiomyosarcomas or sarcomas that do overexpress this. So there is individualized care, but I can't say there's like how we say for ovarian cancer or other cancers or specific ones that we typically see yet. So more, biology needs to be understood in order to figure out better markers.
Thanks, Premal. Dr. McLean, I'm going to go ahead and shift categories and talk a little bit about treatment and clinical trial related questions. I mentioned the HIPEC around mucinous cancer, but there's a question: does HIPEC improve survival?
So we have been really investigating this question in the field, and I want to step back and just reiterate what HIPEC is, which is heated intraperitoneal chemotherapy. So that's chemotherapy that's put directly into the abdomen at the time of surgery to allow the chemotherapy to be exposed directly to the tumor cells. And there have been a number of trials, both national and international trials, looking at whether this improves survival. And the most recent data looking at HIPEC at the time of what we call interval surgery, which means someone starts with chemotherapy, then has surgery, and then has more chemotherapy when they're first diagnosed, and that HIPEC at the time of interval surgery can, in fact, improve overall survival. The question of whether it's beneficial if you start with surgery as far as your treatment plan is a little bit less clear data, in my opinion. And I think that this also highlights the importance to continue to enroll in surgical trials for newly diagnosed patients, not just treatment trials as well. And I'd love to hear the other speakers' opinions on HIPEC as well.
Premal, did you want to add to that?
Well, I would say for us here at Washington University, we have selected cases that we do, but mainly they are at interval debulking, and we're doing a national trial called the HOT trial, HOTT, cute title, to look at this exact question, because the data, a lot of the bigger data series or information has come out of Europe, and there's definitely a lot of centers in the United States that has been doing it as single sites, but we always like to have randomized clinical trial data so we know, is it really the intervention of the heated intraperitoneal chemotherapy that's making a difference versus the standard of care that we might alter a little bit. So stay tuned. But I think, mucinous is one that we tend to use it more commonly just because of the cell type. But high-grade serous, I think a lot of us still want to see a little more data that is from bigger trials, I would say, at our institution.
Mm-hmm. Thank you. I'll take on this next question, which is how will artificial intelligence help ovarian cancer research? It's certainly a timely question, and I would say that it's still very early, in the use of artificial intelligence. But I'll just briefly mention, that there are many places where it could have potential use. it's already been used successfully for designing new drugs, especially around small molecule inhibitors that have entered clinical trials already. So that's certainly an exciting opportunity. And then, the power of AI is that you can feed it a ton of data, and then you can pose specific questions. So in the context of looking at patient outcomes, or looking at how what the genetic makeup of cancers is, and how we can use that for better therapies and so on, I think there's certainly a lot of opportunities here. And some of this is how well it can be used will just depend on the quality of data that's fed into these kind of AI algorithms as well. Personally, one of the things that I would love to see is that as all this testing of cancer samples continues to expand, is to see whether AI-based systems can help us match patients and be aware of clinical trials that are otherwise difficult to keep up with, especially with the pace of FDA approvals and the clinical trials that exist. So again, I think there are lots of opportunities as we move forward, but those are just some examples where it could have utility.
I'd love to add one comment on the AI topic as I've been thinking about it, which is that I feel like early detection is an area where AI might really be beneficial, because one of the things I see as a strength of AI is it has the ability to potentially pull out interactions that we don't even know to ask about or think about. And with this ability to put so much data in, maybe it can identify some patterns that are predicting which patients are going to develop ovarian cancer in a way that we can't even see or hypothesize right now.
Thanks, Sharon. Premal, the next question for you. Comparing debulking surgery first versus chemotherapy before and after debulking surgery, who has better outcomes?
Sure. So that's a great question. And there's actually been 2 very large randomized clinical trials that have been done looking at this question of sort of the sequence, because we all know that both are important, but what is the timing is always the big question. So they have shown similar outcomes in terms of survival. So that it gave us, I think all of us, pause to be like, because as surgeons, we've always thought surgery is best. And if you're a medical oncologist, you thought chemo is best. And now we realize there's randomized clinical trial data to show they're equivalent. The key is to go to a center where they actually, perform these surgeries very commonly. So they're, trying to get you the best outcome to get the least amount of disease left. So the amount of residual disease is really important. And so I think that's where we are talking about sort of deficiencies. Even though we try to get your tumor markers and your radiographic imaging, we know there's limitations of all of that. So a lot of us have gone to diagnostic laparoscopies first to look inside the abdomen to try to get the best understanding of what's happening inside to make that critical decision of chemotherapy versus surgery first, as well as to get also profiling done for patients so that we can start that understanding of personalized medicine for each individualized patient too.
Karen, there's a question about, can you talk a bit about what are treatment options for patients with platinum-resistant relapse ovarian cancer?
So the options in that scenario are many, and it is in fact because we don't have a really clear answer of what the best next choice is. So what we're talking about is patients who've had a recurrence of their disease generally within 6 months of their last platinum-based treatment. And so at that time, we're making the decision that platinum, generally carboplatin, sometimes cisplatin, isn't the best sort of backbone of their treatment. And so there are a lot of different strategies. Some are the more historical treatments that many folks have likely heard of, as far as medications like Doxil, gemcitabine, topotecan. Sometimes we'll add bevacizumab or Avastin to these medications. But the challenge is none of these medicines work as well as we would like. And so one of the things that I think is really important at this stage is to consider enrolling in a clinical trial for the potential that you're personally receiving a treatment that's going to work better than what we have, and also that we might be able to develop better treatments for patients in the future. I tell folks that whatever treatment we have now is our standard once was a clinical trial that someone participated in, and that's how it got to be part of our standard of care. And so I actually think we're making a lot of progress in this category of platinum-resistant disease. There's been mention of Elahere, the targeted therapies, we call some of those antibody drug conjugates, in which we're trying to bring a chemotherapy drug directly to the tumor based on the proteins that tumor expresses. And so there's some exciting new advances, and I think it's just going to hopefully keep on moving forward. I saw a question in the chat about whether there are going to be more FDA approvals, and that's absolutely what we're all hoping for, is better treatment options.
Thank you. I'll go ahead and comment on this next question, which relates to low-grade serous carcinoma information and progress related to it, and focused on and research on rare ovarian cancers and so on. This is actually a very timely topic. Tomorrow I have to give a talk at the in Charlotte at the SGO Allied meeting on rare ovarian tumors, and we'll certainly cover this topic there as well, as long as the hurricane doesn't disrupt the meeting venue and so on. But for low-grade serous cancer, a few points. One is that even though within the what we call histology or type of cancer, it's called serous cancer, but the grade of cancer as a low-grade type of cancer is something that is a rare tumor in that it represents about 10% of the serous cancers. Now, what's unique about this is that it's not like low-grade cancers can become high-grade. They cannot. These are completely different in their genetic makeup and the way they're treated and so on. So with regard to treatment options, low-grade cancers tend to be much more affected by hormonally targeted drugs. So drugs such as what are called aromatase inhibitors or letrozole or estrogen receptor blockers. And there's certainly other classes of these kinds of hormone blockers. A second class of drugs that certainly has activity in this cancer type is bevacizumab, which is a drug that targets a blood supply to cancer. And that can be used on its own or in combination with chemotherapy. There was a large-scale clinical trial done with a drug called trametinib, which is a drug that targets this gene called KRAS, which tends to be more frequently mutated in low-grade serous cancers compared to high-grade serous cancers. And it actually showed, reasonable activity. We obviously need to do better than what we've seen even. And then there are many other emerging areas, such as something called a CDK4/6 inhibitor that's combined with one of the hormone blocking drugs. And there are also some really nice developments with something called focal adhesion kinase or FAC inhibitor that's combined with these MEK inhibitors. So it's an incredibly active space. And I think that in the next 5 years, we're going to see some pretty significant advances in treatment of patients with relapse low-grade serous cancer. And very importantly, even upfront. I think there are many people who are asking questions such as, is chemotherapy really the best option up front, or are there other biologically targeted drugs such as the CDK4/6 inhibitor combination that I alluded to, that where the patients may respond a lot better? And there's small-scale studies that certainly point to those kind of findings. So please stay tuned. This is just a rapidly moving area for clinical trials and development and so on.
I would just add one more thing. I think it's also a great testament of how clinical trials can be done in rare tumors, like which is really important. Because every one of you, as Dr. McLean said, the drugs we give today are really because of trials, and the sort of enthusiasm we have is because there are newer drugs and newer targets that we're all excited about. But until there are trials, we won't know the potential benefits for patients.
So Dr. Thaker, now I'm going to shift categories again. This is a question about CA125 and testing. I'm just going to combine two questions together. What does it mean when the CA125 is creeping up slowly by 1 or 2 points every 2 or 3 months? And what does it mean when the CA125 level keeps going up, but there hasn't been any clinical evidence of tumors and so on?
Yeah, so a CA125 is, the shedding of a protein in the bloodstream that can be detected. So it's not sorry, someone muted me. So sorry about that. It's not an accurate test, so we haven't been able to use it for screening, and nor is it that accurate for necessarily always saying the status of your disease. So, we definitely use it as a good biomarker when patients are newly diagnosed because it's elevated, and then watching response. But once it's sort of, when you get in remission and your CA125 hopefully normalizes, there's always normal fluctuation. And so when it creeps up 1 or 2 points, we don't really make much of it. Because really we sort of try to look for symptoms, and we know that radiographic imaging also does not detect, that level of maybe recurrence either. So I'd say it's definitely, patients use it as, of course, a test to say, this is my report card, and I understand that, but I also try to give patients that grace to realize that there is normal fluctuation, because otherwise you'll get a lot of anxiety over this even 0.5 that it might have gone up, and it's not even a full point. So that's how I sort of counsel patients, because really usually symptoms are the main way to detect recurrence, but we try to use that because we have limitations of everything we're saying, radiographic imaging or pelvic exams, or even sometimes symptoms for patients will be the best way to detect.
Dr. McLean, what is the role of a Signatera test, and should a patient be pushing for it?
So I'd love to hear everyone else's comments about this. It's not an area I'm as strong in. It is a test looking for circulating tumor DNA and looking for like a blood test to try and detect cancer. And I would say at this stage, it has not gotten past or isn't better than the other testing that we have for following ovarian cancer. So I don't think it's going to add at this stage to a patient's care, but that's my thoughts on it, and I look forward to your thoughts as well.
No, it's an important question, and it's here we've tested it in a number of patients with ovarian cancer, and it may have what we would call some differences in terms of prognosis. But we don't really know at this point, how to exactly use the information. In patients with colon cancer, there's certainly a lot more data. So my view, with the Signatera test is that, again, it's early, but there are clearly patients who've had cancer where the Signatera ended up coming up negative. So we're not quite sure how precise or how accurate this test is going to be. We simply need a lot more data, before I would say that we can rely on it in any way, for recurrence risk or for even picking therapies and things like that. Premal, did you want to add to that?
No, I think those are all great points. I think, it's being marketed as like a way to be the minimal residual disease and, to sort of reassure you. But as everyone said, it's still a learning curve. And, we did the same sort of test with like CA125, as people asked earlier about, if it's inching up, is there sort of, something that you should be intervening or doing earlier? And what we found, at least looking at CA-125 in a very old study, was that until it reached like 100, that's when it was sort of like a tipping point, not when it was, went from 35 to maybe 40, because it got patients on therapies earlier, but at that time we didn't have therapies that were impacting the survival. So as anyone who's been on therapy knows, that the sooner you go on therapy, there's also side effects that come with it. So when you talk to patients, at least in my practice, I feel like everyone wants to know, what is the survival advantage I'm going to have by taking that therapy too? And so I think it's this balance, because just because you detect something, as Dr. Sood mentioned, doesn't mean we know it probably says something about your prognosis, but that we would also say if you're platinum sensitive or resistant, that also tells you something about your prognosis of how your cancer will be in terms of the journey. But with more and more studies and more data, we'll have better answers. So as we are saying, for some things, stay tuned. We're still learning.
All right, the next question I'll tackle, and Premal and Karen, please feel free to add in. And this relates to in a patient with a history of endometrioid ovarian cancer. Is that a contraindication to hormone replacement therapy? It's something we spend a lot of time actually looking up, and the Society of Gynecologic Oncology actually published a position statement around this within the last 3 or 4 years. There's certain types of cancer where it really would not be recommended to use hormone replacement therapy. And a couple of those examples would be, say, patients with a granulosa cell type tumor or a low-grade serous type of cancer. Beyond that, there really hasn't been consensus around this at all. And there are pros and cons. So it's not a question with an easy answer. I think that there have been some varying size studies done that have shown that in patients with, for example, high-grade serous cancer, that it could be used. But I think some of us also worry, though, that about a quarter of these cancers can have the receptor for estrogen being present on the tumor. Whether or not that affects the outcome of a given patient, we just don't have high quality data around that. And that's why I mentioned that there hasn't been absolute consensus around this complicated question. Premal and Karen, please feel free to add in.
No, I agree. And I think fortunately, we're getting better at some non-hormonal treatments, right, for the symptoms that really bother patients. They're not perfect, but, I think it's shared decision-making in these situations. And I think it's really important to have that conversation, because everyone's risk tolerance is different, of what the symptoms are. And the importance is not noted by all of us, but it's also the concern, as Dr. Sood mentioned, about, stimulating a cancer, and there's not a consensus. And when you're in that gray zone, it really has to be, in my mind, shared decision-making.
I would just add to that there are many subtleties to the cancer that we know well as your treating physician, what stage it is, how long ago it was. The pieces we don't know so well is really how your life is being impacted by being postmenopausal. And so I would empower all of you to really express that to us and say, yes, but hear me, this is a problem if that's the situation, because we only know what you share with us about that part of how you're feeling.
Dr. McLean, continuing in the same category, this is a kind of a broad category. Can you talk a bit about the links between endometriosis and ovarian cancer, and some of the research that's being done?
This is a field where I would say we're making a lot of exciting progress, because we are learning that we call them endometriosis associated ovarian cancers are different than high-grade serous ovarian cancers. And endometriosis does slightly increase a woman's risk of getting ovarian cancer. And it would be different subtypes, specifically endometrioid that we were just mentioning, as well as another less common subtype that's called clear cell ovarian cancer. So those two subtypes are associated with endometriosis, and they have a very different underlying genetic basis for their cancers, different mutations. One that we think of as a protein that's called ARID1A. And so there's a different category of treatments that might be effective in patients with these subtypes of ovarian cancer that are specifically based on how the cancer arose in the beginning. And so it isn't yet changing where we start with treatment. Folks still get the same starting treatments, but then in the recurrent setting, this is where that topic of molecular profiling, defining the mutations in your tumors is really going to help us know what's the best next step for your treatment specifically.
Thanks. Premal, the next question, I'm going to frame it a bit broadly because I think the way it's written is a bit specific. And this relates to the use of talcum powder and as a cause of ovarian cancer. It's clearly been in the media a lot over time. So the question is, can you speak about the evidence and thoughts about, legal counseling, et cetera? This comment actually mentions that, she does have concerns about pinpointing one product as a cause of the ovarian cancer. But can you just talk, a bit perhaps broadly about, talcum powder and ovarian cancer?
Yeah, I'm not the expert on that one. But, I would say some of the thoughts of, the talcum powder is that there potentially was, other ingredients in the powder that might have led to this. But, these are really hard ways to figure out these associations because, it's looking back and trying to know how frequently did someone use it, which exact type did they use. So it's, in my mind, not a clear association. It's not one that, I can say I have great expertise in. So I'd love to hear if anyone else on the panel has other thoughts that they would like to share.
No, I think, the risk that's been shown is mostly from what would be called epidemiological studies, and the risk is not real high, but there is a consistent, risk that you tend to see from these. So Dr. Dan Kramer, has really championed this field, who first made this link between talcum powder and the risk for ovarian cancer. But I think, hardcore mechanistic data to prove that that's the cause of ovarian cancer, I think that's really difficult. And that's what I think was mentioned in this comment as well. Karen, if you have anything to add, please feel free.
I would just add that because of the concerns, I think there have been widespread manufacturing changes to try and make sure that there's not talc in the powders now and that products are as safe as possible. So I find that is somewhat reassuring as well.
Sarah, I think maybe we can do one last question and then we'll take a break.
Yeah, that sounds great.
Okay. All right. So this I'm going to ask, I'll start, but I'll ask both Dr. Thaker and McLean to also comment. What are some suggestions to treat neuropathy in the hands and feet? Will neuropathy go away after chemotherapy is done? So one of the things that I discuss with patients is that, in my mind, neuropathy is not just of one type. It has a lot of variability in terms of what the dominant symptom is. There are patients who will have numbness as the most dominant factor for neuropathy. There are others who have, what we call paresthesias or what feels like pinpricks. And then there's a third group who just has pain, or there can be a combination of, between these three. And I think thinking about the type of neuropathy is important because as we look at some of the evidence, for example, with the numbness type of neuropathy, vitamin B6 or pyridoxine given at higher doses is really among the few things that's been shown to make a difference, apart from changing the chemotherapy drug and so on. Whereas for the second type, the paresthesias, there's an old antidepressant called amitriptyline or Elavil that used at a low dose once a night can be actually quite effective. And then for those with pain, things such as gabapentin and so on are the drugs that can be used. So I think that it is important to think about what kind of neuropathy somebody's having, because the options for intervention, I think, can vary depending on, and if we're more precise about the type of neuropathy, I think we tend to have a better effect. In my mind, for example, prescribing gabapentin to somebody who has just numbness as a dominant component doesn't really help, because it's not going to treat that type of neuropathy. Premal and Karen, please feel free to add in.
No, I completely agree. I think the other thing that I also sort of talk to patients about is like occupational therapy as well as like physical therapy to try to help, because it's debilitating, and then trying to help compensate, by either, getting some assistance, because sometimes people will be like, I'm just dropping objects. And then there's definitely occupational therapy sometimes has different devices to assist patients or make things easier, because opening a jar can become an issue in your kitchen or something. So I do think those are other adjuncts that I also add, because it is something that we combat all the time with our patients.
I agree with both the medical and the occupational therapy strategies. And then I just wanted to add about the part of the question with regard to whether the symptoms are permanent, and that they can be permanent, and therefore it's something that we really want to follow. Patients who have experienced the symptoms, firsthand that at first they may be waxing and waning, and then they may become more persistent. But if they're extending more than 6-12 months, then it may be getting harder for us to get rid of them if they're not getting better at that time.
Thank you. So how about if we take a 8-minute break, and then we can start right at 2 o'clock Eastern time?
Sounds great. Thanks, everyone.
Thank you.